Hello and welcome to a new episode of Majlis Podcast by Emirates Hospitals Group. My name is Wael Berro and I'm a family medicine consultant at Emirates Specialty. Today, in this special episode of our podcast, it's an honor to host Dr. Tarabishi, our consultant orthopedic. Dr. Tarabishi.
Thank you very much. It's a pleasure to be here. My name is Dr. Samih Al-Tarabishi. I am an orthopedic surgeon. I have special interest in joint replacement surgery. I have been in the business of joint replacement for over 40 years. I have done my training in the United States and I have practiced in the States for 10 years. And then I moved back to Dubai about 30 years ago. Right now, I am the head of the Joint Replacement Center at the Emirates Hospital.
And it's a really pleasure to have you at our group and also today at our podcast. And I'll be the medical student today. I have lots to learn from you, I have no doubt. But let's start with your expertise. Joint disease, osteoarthritis. What can you tell us about it? What can you tell us about also the prevalence, but more important, because we're all about prevention, what are the risk factors and what do people should do to prevent osteoarthritis as they get older?
Osteoarthritis is a very common problem. I wouldn't call it a disease because it's a tear and wear. Sometimes I tell my patient that it is like having cavity in your tooth. That's not a disease. That's usage and, overusage sometimes. So you erode, you lose the coating of your teeth. And that's exactly what arthritis is. Arthritis, the common osteoarthritis, is not a disease. It's rather than where the patient loses the cartilage covering the bone. And when he does lose the cartilage covering the bone, then the bones start rubbing with each other, causing a great degree of pain. Of course, there are a group of disease that we call them rheumatoid and rheumatoid-like disease. Those are separate entity. And those really does not constitute more than something like 10%. In rheumatoid-like disease, the autoimmune system in our body attack the cartilage. So this is different. But the majority of the people, especially the elder people, when they develop arthritis, it's a tear and wear phenomenon. So they use the cartilage. And the issue is, the problem with cartilage, it does not regenerate by itself. So when you lose it, you lose it. It's like nerve cell. It's like eye cells. So when you lose it, it's never coming back. So, when you say that, what's the prevention? Well, the prevention, there are certain things that we can do, but there are certain things that we cannot. The thing is that we cannot affect is the genetic, how good is your cartilages, and that's not in our control. But osteoarthritis has been in the rise for probably two main issues. The first reason is the fact that people are getting older, they're living longer. Before people did not live that long. Now they live a long time. 100 is not rare these days. And the other reason for it is really the obesity. The obesity and overweight is really on the rise. If you take the statistics in the United States, they're horrible. People are becoming overweight, and the number of overweight people is on the rise. So when you're overweight, you tend to use your cartilage more. Not only that, there are studies that shows that if person is overweight, the fat tissue will secrete some material that will affect the cartilage and make it erode. In other words, an obese patient is not going to only erode the weight-bearing joint that he has, like the knee. He's going to also erode the hand joints. Why is that? Well, because his body fat is secreting material that is really damaging the cartilage. So look at the osteoarthritis as a tear and wear phenomena. So what can we do to prevent it? The weight is a very important issue. Second is really to avoid like damages like sport injuries or, as much as possible. So when you have a problem in your knee, attend to it early, because sometimes if there is a problem, it's manageable. And also sometime if there is an early pain in the joint, you should see a doctor. Why? Because if it is a rheumatoid-like disease, you can do something about it medically. So again, the prevention is simply weight reduction, being careful about your joint, and avoiding injury. And when I say avoiding injury, I mean in sport in particular, because a lot of time I get to my clinic people who get overexcited and do things over beyond their capacity, and then they hurt themselves. And when you hurt yourself, you're using your cartilage in a way or another, and that probably can increase with time to being an advanced osteoarthritis.
Very good. Thank you. That's a very nice summary. And I'm glad you've actually already covered the concept of obesity, because like you said, 60+% of the world population is either overweight and obese. And with living longer, then it seems like this natural progression is an inevitability. The question how we can maintain as long as possible.
Yeah.
So let's say I've started having some joint pain and I'm a bit worried about my joint. I'm not worried about rheumatoid. I think it could be a bit this wear and tear, the natural progression of my arthritis. And then I come see you. What is the process, and when do you start considering joint replacement?
The damage that you get to the joint is a degree. There is a mild, there's a moderate, and there is severe. Severe means you have lost the cartilages. Our job, like a doctor, and I always tell that patient, to the patient when I tell them that you have arthritis, but wait a minute, our purpose or our main treatment goal is to prevent the progression of the disease. So the point that I'm trying to tell you, not every patient who has arthritis is going to end up being operated. We normally say the indication for surgery is advanced OA, advanced osteoarthritis, and pain and disability affecting lifestyle.
Absolutely.
Meaning, if I have a patient who is starting not, I'm a surgeon, I have to work, I have to stand up, 6 hours. If my knees are affecting, preventing me from that, then you have to consider doing something. The point that I'm trying to say here is like I see large number of patients. Those who need surgery is really a very small percentage. So if you have an issue, visit your doctor. Don't be afraid that you're going to have operation. No, because sometimes it's all like instructional thing, and we're going to ask you to do some exercises to protect your knee. So most of the treatment for osteoarthritis is really what we call non-surgical conservative management.
And that's absolutely a good point, because I remember this from many years, even when I was a junior doctor, even trainee. We always used to say, you treat the patient, you don't treat the result or the x-ray. So if the x-ray shows severe arthritis, but I'm not in pain and I'm functioning, then maybe I don't need surgery compared to someone else with similar findings.
Absolutely. Yeah. You really touched on a very good, valid point, because sometimes they bring me a patient to my clinic, and the patient, tells me that, hey, I don't have pain, but you're in a wheelchair, for heaven's sake. You're not walking. So you always have to talk about function. The whole idea is to keep people functioning and living normally. Why we insist on people moving? Because the minute you start, decreasing your activity, you're gonna, what we call, compile the diseases. Absolutely. The diabetic is gonna get worse. The hypertension is gonna get worse. There is a very interesting study that was done in the United States where they tried to find the benefit of joint replacement. So they were trying to compare two groups of people, those who had surgery, those who did not have surgery. And ultimately, their conclusion was those who did not have surgery has much more medical problem than those people who really did the surgery and went on with your life. Remember, the movement, the walk that we do is really good for our heart, good for our lungs, good for everything, practically. The minute we stop doing that, you're going to have a problem. So their conclusion was, for not only the knee health, quote unquote, for the patient health, to keep him moving, because most of the Western and American patients live alone. And if he's alone and he's non-functional, that's a big issue.
Absolutely. And this is just without ignoring the mental element of being in a wheelchair, being actually disabled and not able to look for yourselves. And as we used to say, the activities of daily living. Are you able to do the ADLs and then look after yourself?
Yeah. I see that quite often. Sometimes I get a patient in my office, I speak to him, and he does not answer, as if he has given up on everything. You have to know something, that statistically people who do surgery and get rid of the pain and disability, the outcome of their surgery is much better those who waited until they are completely disabled and then they had surgery. The success rate of the surgery of people who coming to my office is 98 percentile.
That's very impressive.
Why? Because they're walking. They still maintain the muscle. They still maintain their strength. They still maintain the interest in life. If you have an interest, if you're a busy man, actually, that's a very good indication of how successful the surgery be. The best patient that I had are those who are linked to something. I have business people. They were anxious to go back to work. They did much better than those people who are used to a wheelchair. Why? Because he's still motivated. I had local ladies here who are just anxious to go back to their sheep so they can take them to the mountain. They did much better than people who are in a wheelchair. So again, yes, you're practically, slowly kind of the patient decline, even mentally.
Absolutely.
They deteriorate mentally, no doubt about it.
And I wanted to ask you more about surgery because, like you mentioned, yes, it's not for everyone, but when it's needed, there is that fear that I've had my knee replaced, I've had my hip replaced. So there's always that psychological element for decades that's it. It's the beginning of the end. And surgeries have changed. I think the technique, the success, 98% is an impressive, actually, success rate. What can you tell us about the surgery itself in terms of success and in terms of the prevalence? I know you've trained in the States, but even if we can compare data to States or data here with your experience locally.
The surgery, it's not like every time I tell people, we're talking about knees now. I'm not going to address the hip yet. But the knee, when we do surgery, people think that a lot of people think that I take off the kneecap. A lot of people think that I chop the bone and I put a replacement. No, that's not the story. What I do is I resurface the bone. That worn out surface, I normally clean it and cover it. If you want to give an example of that, it's like dentistry. When you have a cavity, what the dentist does is clean up your cavity and he cap it. And this is exactly what we do. So we don't touch the ligament. We don't touch the muscle. We keep everything. We just resurface the joint. So as if we're giving it a new coat. I'm covering it with an artificial layer instead of the cartilage that the patient has wore out. Interestingly, what is the difference between here and the US? I practice in the state, and when I came here, I was kind of shocked by two things. First, the local patient here in the Middle East wait until they are so far in the disease. The Westerner don't. They usually have confidence in the surgery, and they tend to attend to themselves earlier than the Middle Eastern. So that's the very important. The cases that I do here is much more complex and demanding than the cases that I used to do in the United States. Because in the United States, with the health care being available for everyone, they probably attend to themselves faster. And the second thing that was really kind of for me was a great journey for me, to be honest with you, is the fact that I noticed, like I told you, when you do a total knee replacement, you're practically resurfacing the bone. So when I came here, I immediately noticed that, from the day I opened, firstly, that the sizes are different and the angles and the shape are different. And I did work on this, and I kind of did a presentation in the US about the Asian knee and the difference of the Asian knee from that of the European. You have to remember that most of the joint replacement companies are Western company, American.
Yeah.
And when they did their artificial joint, they did it according to the sizes of the European. So the angle were different. And again, we presented that, we published that, and I was part of a team with one of the biggest company in the world. It's called Zimmer. I was a part of the designer. They asked for my contribution, and it was kind of a very pleasant experience for me, because it was based on finding, on data. So I modified the joint. It's not only me who modified, it was a joint effort, but they took really all the recommendation that I made. And one of the recommendation that I told them that our patient in the Middle East like to kneel down. So this company was the first company to produce a full flex joint. When I was in the States, nobody asked me to sit on the ground. But here it was really something important and dear to the heart of a lot of Asian patients, because it's their lifestyle. We normally label it as activity of daily living. So we did the changes. This journey took about a year, where I practically traveled like every month to the United States, back and forth. It was hectic, but enjoyable.
Yeah. And you made the difference. You've actually only of academically on the personal level, it's very interesting. I wasn't even aware of the genetic variations of the knee sizes between Asians and Europeans.
It is well documented now. There is, tons of paper, because initially when the surgery was done in Europe. So they attended to the what we call Caucasian need. And now the company, not as of, I'm not saying that they did that as of goodness of their heart, but they did that as a business, because they know
it's a big market.
The big market is the Asia market. The explosion is happening in the Asia. The population increase in the Asia. So they did some modification that made the implant really much suitable for the Middle Eastern patient.
This brings me to the next question, because you've kind of highlighted it in a way. Publications, research, and then your expertise and contribution to modifying joints locally. You have an impressive CV, and I'm not in a position to actually explain, but more than 40 publications. I think you have patents in your name. How did you combine all of that? And can you summarize some of the work you've done, actually? Because you highlighted the work and publications, how it influenced your practice. But what contributions did you personally make in terms of the patents that you have under your name?
I have under my name an 8 patent in the United States for joint surgery. I have published, over 40 papers in American and European scientific magazines. So it's very credible.
I see your point, yeah.
And I wrote book chapters in a few textbook in the United States. And my interest, it was really kind of the whole thing started from me, when I was in the United States, and there is a differences. You are dealing with the same principle of surgery, but there are differences that you have to attend to. And those differences, you have to address it. So I kind of tackled each problem separately. But in order to stay in line, I can't sit in my hospital and say, okay, I want to do that. It's not going to happen, first. And second, it become like illegal. So every time you have an idea, you have to take it through the route. An engineer has to look at it. And, they have to say, yay, nay, modify this. I can't do that for you, doctor. I cannot do that for you. When I was in the designer group, it was interesting. It's a big company that they kind of joined in the same hall, about 20 world famous surgeons. And they have like about 10 engineers, and they have even marketing people. And we were interacting. So in other words, it was on the spot. When I say something like, okay, I want to do this modification, the engineer would stand immediately, not waiting, and say, what do you mean exactly? What is the benefit? The businessman would stand, and say, you have to give me, numbers, because if I do this, it's going to cost me X amount of money. And this was really, for me, a very unique experience, because it was kind of what we call an interdisciplinary approach. It's not like, okay, here, you dream. And this has to go through the FDA. And they show you what is the process and what can you ask for. The FDA is the United States Drug Administration. And so there was multidisciplinary approach, and you have to go through that route. You cannot, go and make your joint in a shop. There are standards. These things are practically protected by many barriers. The FDA takes very long time, sometime, to approve a concept. So to me, it was a good journey, because I knew, I never knew that, how does the FDA think? What is their requirement? But again, it's a multidisciplinary approach where you can change things. And I took it in the right way, I took the right path in doing that, through publication.
It takes patience, dedication, and perseverance, no doubt. And,
yes.
And on behalf of all the patients that benefited, I would say thank you, because many would probably have stopped halfway because they lose that momentum, because you're keeping your clinical practice running while you're doing this on the side. Now, I want to go back to the concept of pain management, if you allow me, because we mentioned pain is a very important, besides the activities of daily living. We want to manage pain in the best way. Surgery is one way of managing pain, but I believe there's something that you do during the surgery to control pain. Can you highlight more about this treatment? Is it an injection, or is it something that you do that you ensure that patients remain pain-free for longer?
In total joint, in total knee particularly, it's a painful surgery. You want to there's no doubt about it. And the pain management is also multidisciplinary. What I mean by multidisciplinary, it is on multi-level. Multi-level meaning that you give something to affect the nerve cells centrally, and you give some medication, you give an anti-inflammatory medication. This is the brain level. Second level is the spine. Sometimes we do epidural injection to control the pain. Third level is where that pain starts. And we normally try to inject the joint with a special late kind of analgesic during surgery. But this lasts usually for a couple of days in the first 2 days. But what we have been doing recently, and we published that, is we have been freezing the pain nerve. When we do the surgery, after we finish, we can localize the 3 major pain, for pain in the joint. We can see it in surgery.
Like in nerve endings, kind of.
Like so you can see it. It's a small thing. So what we are doing is we're doing a cryo for this nerve. So we're freezing this nerve pain. And when you freeze this nerve pain, you put it out of commission for like 3 months, which is what the patient want.
Yeah.
Because the pain is only in the 3 months, because he has to do
Yes.
physiotherapy. So it's not killing the pain 100%, because there are smaller, tiny nerves that you cannot find. But it's really reducing the need for narcotic pain. We did a study and we published it in the United States that shows that people who did the cryo treatment required like 50% less pills, which is quite considerable. People don't like to get painkiller. So I think this has been a great breakthrough for doing total joint replacement.
And that's only intraoperatively. So this is done only during surgery. Do you think this is something that we can reciprocate or replicate? Sorry, apologies. Like whether you do like a keyhole procedure with the camera, or at the moment it's only during the surgery itself?
At the moment of doing surgery.
Okay.
Initially, when people started using cryo for total knee replacement, they used to bring the patient to the patient before surgery 2 weeks, and they freeze those nerve. They freeze it both based on the ultrasound. They don't see it well, but they freeze it like they do needle, and they freeze it. So that was the most common technique. So we figured, why don't we do like the thoracic surgeon does? Thoracic surgeon, when they open chest, the most painful thing if you open chest for cardiac or for any reason are really the rib that they have, to break before they go into the chest wall. So thoracic surgeon did the cryo for those nerve, we call an interthoracic nerve. So, I was listening to that. I said, why don't I do the same thing? It's kind of funny how the idea is. So in a way, we imitated them, and it worked.
That's
Okay. And we're having really a great run with it. Interesting, I had done a patient, I done both knees. And the machine for her lock did not work on the second knee. So we said, okay, what else you could do? Finish up. That lady noticed just like that. And she always kept telling me, this knee is hurting more than this knee. Why? So I told her frankly what happened, But it was striking to me, how did she notice it? It's almost like doing what we call double-blind study, because she did not know that I didn't do the second knee, but she experienced it. So they asked me, if it was not this effective, she wouldn't have noticed.
And that's all about what we were saying earlier. It's about the quality of life that we get from any procedure, and that's really impressive. Now, as a joke, I'll say it without revealing the age. You have massive experience. You've been doing those surgeries since late 80s, I believe. Now, with experience, with innovations, things are changing. How do you describe the journey of knee replacement in the last 30 plus years?
I think, the progress has been gradual, and that's the way it should be. What I'm trying to tell you is the progress with joint replacement has been progressive throughout the time. It did not stop. And we have so many techniques, like you have the robot, you have what we call the patient-specific instrumentation, and each thing has given the surgeon what I call more options to deal with particular case. Today, joint replacement surgery is more individualized. In another word, it varies from patient to patient. Medication varies from patient to patient. And that's normal, because, people are not the same. And I think recognizing this, what I call personal approach to the patient, has helped us in obtaining better and better result. Before, the whole idea was to have patient just to be able to go to bathroom and to the kitchen without pain. But now patients are more sophisticated. They want to sit on the ground. They want to do some sport.
Yeah.
They're not the same patient. They're not gonna. In another word, I sometimes give it like the example of the T car when Ford started a T car. One color fits all, one engine. So he had only one car.
Yeah.
But it was an invention.
Yeah.
But then after that, you have so many cars. You have a sport car. Already to attend to what is the customer want. Same thing happened with the knee. We fine-tuned thing. So, even the sizing of the implant used to be, a bit crude. Now we fine-tuned it. Everything fits much better. The recovery is faster. So the result has been progressively getting better, and that is for the benefit of patient.
Absolutely.
The technology is getting better. Everything has been getting better. It was when I say that the success rate is 98%, that's compare it to other surgery.
Yeah.
That's a huge.
Oh, absolutely.
If you compare it, say it with spinal surgery has much more limited outcome. But knee surgery has a very, total joint replacement had a very rewarding, the acceptance of this surgery when I started, like over 30 years when I came here, was initially difficult. People did not accept it. And now the acceptance is much easier. And you have to know that in the United States, 1.5 million knee replacement is done annually. In Europe, it's 2 million. Just think of that number. It's a huge number.
Yeah.
We have done over 30,000 cases. So it's not anymore like, surgery, the experimental. No. It's a solid science. And I always tell the patient that your chances of, getting problems if you don't do the surgery are much higher if you don't, And I'll give you an example. There's a study was in England. They took the percentage of hip fracture, which is a common problem in elderly. Guess what? It's much higher than people who don't have knee surgery than those who had surgery. But that makes sense.
Because it puts less pressure.
Yeah, because the patient now can, depend more on his knee. A lot of my patient tells me that my knee doesn't hold me. Yeah. So they break a hip. So the percentage, in other words, I always tell the patient, the risk, you are much at a higher risk if you don't do the surgery. If you think, that because of 2% complication, that is manageable. It's not only complication where, it's a failure. No, that's manageable. We can do something about it. And our statistic it's really even better because we have a database. But the point that I'm trying to tell you is if there is a 2% complication for the surgery, there is much higher complication rate if you don't do the surgery. Not only on your knee, but also as well on your health.
And I'm sure for our audience today, that's very rewarding and reassuring to hear. And maybe in a way, instead of thinking of it as the beginning of the end, it's rather actually the beginning of the new story or the new chapter.
Oh, absolutely. Yeah. Absolutely.
Now, I can keep you here for hours because it's very exciting. But I have one last question, if you allow me. And because it's more probably critical topic. It's the revisions of a knee replacement that didn't work. And I believe you have a patent in that as well. So, because it's definitely a difficult topic. Someone that has done their surgery 20 years ago, but it was the old repair, and then things have got worse. They come to see you. What do they expect, and what do you advise? And where is your expertise and the patents you have in that field?
Revision surgery is much more demanding and it's much more difficult. I had the opportunity of participating, of designing a revision system for the knee. Revision system is really, in a way, I told you that there is like 2% chances of complication. This is not the end of the road. And that's, in another word, okay, my surgery, there is a problem. I don't feel comfortable. Well, that's not the end of the road. That's not the end of the world, you know. There are things that we can do. We can revise the implant. Initially, we define what is the problem of the first implant. Sometimes it's overhang because the joint is oversized. Sometimes the ligament is not balanced. You know, sometimes it's just the joint itself had become loosened after, 20 years. Then that's not, you just don't keep the patient in a wheelchair. No, there is hope. But the surgery becomes more complex, more demanding. The implant is more complex. The implant and revision system is made so it can make up for any deficiency. To give you an example, if a patient has a bone loss for some reason, I can compensate for that bone loss with metallic bone. We call it metallic bone. In other words, it's another hope for the patient to say this is, you're not going to get disabled and be in a wheelchair. We'll solve your problem. But it is always more complex surgery. It needs a surgeon who does revision surgery, and it needs a surgeon who analyze. You have to analyze what's the problem. So every time I had a patient who said, I had surgery, but I'm not feeling better, nowadays you can analyze and find out why he is not feeling better. And most of the time you can find some reason and cause, and you can correct it with the revision system, though, not with the primers. So if there is instability, whereas the revision system, I can correct that because the revision system offers different level of what we call constraints, so it can make up for deficient ligament. So the issue is you have to know, though, that in revision surgery, you have to go to a special center. In another word, you have to go to a center where it's well equipped, that has everything, because I can't, in the middle of surgery, say, well, please bring me this. No, it has to be right there in the theater. All the options, so there is no surprises. So even in Europe and the United States, the revision only is done in a specialized joint center. It's not done in every hospital, but it is a successful surgery. And, I have done quite a large number of people who weren't happy with their initial surgery, and we revise it and they're happy, and, they're back to their life in a way or another.
That's very nice. And again, I'm sure people would love to hear this because there's hope, and that's never lose hope, and always make sure that you see the expert. Dr. Tarabishi, thank you very much for your time and for your patience.
Sure, you're welcome.
This brings us to the end of our session today, and I hope you've all enjoyed as much as I did enjoy today's episode of Al-Majlis Podcast by Emirates Hospital Group. Thank you for listening, and stay tuned for another episode very shortly. Thank you. Thank you, Dr. Tarabishi.
Thank you. Thank you very much.